Your kidneys can lose up to 50% of their function before you feel a single symptom. No pain, no warning, no alarm, no alarm. By the time most people find out their kidneys are in trouble, the damage has been accumulating quietly for years, sometimes decades. And here is what makes this truly dangerous. Millions of Americans over 50 are taking medications every single day, medications their own doctors prescribed, that are slowly degrading their kidney function with every dose. Not because the drugs are bad, because nobody explained how long is too long, how much is too much, and what combinations become toxic when you stack them together month after month. That conversation should have happened at the pharmacy counter. It didn't. So it is happening right now. Subscribe and hit like. What you are about to hear could genuinely save your kidneys. Help Dr. Johnson reach 100,000 subscribers. The system does not profit from this conversation. I do it anyway. Before I walk you through the 9 medications, you need to understand what you are protecting. Because most people think of kidneys as simple filters. They are not. They are 2 fist-sized chemical processing plants that clean your entire blood supply roughly 40 times every single day. Inside each kidney sit about 1 million tiny filtration units called nephrons. Each nephron contains a cluster of microscopic blood vessels called a glomerulus, wrapped in a capsule and connected to a long winding tube. Blood enters under pressure. Waste products and excess fluid get pushed through the filter walls. The useful substances, water, glucose, essential minerals, get reabsorbed back into the bloodstream through the tube walls. What is left over becomes urine. Now here is the critical point that changes everything. Nephrons do not regenerate. When a nephron is destroyed by toxic exposure, by inflammation, by chronic pressure, it is gone permanently. The remaining nephrons compensate by working harder, which masks the loss. You feel fine. Your urine looks normal, but inside, the workforce is shrinking, and every single medication you swallow passes through these filters. Some pass through cleanly, others act like sandpaper on the nephron walls. The first medication on this list is the most common kidney-damaging drug in the world, and it is sitting in almost every medicine cabinet in America: NSAIDs. Ibuprofen, naproxen, Advil, Motrin, you know them, you trust them. Here is what they do. NSAIDs block enzymes called COX-1 and COX-2. That is how they reduce inflammation and pain. Very effective for that job. But those exact same enzymes play a critical protective role inside your kidneys. They help produce substances called prostaglandins that keep the tiny blood vessels feeding your nephrons dilated and open, block those prostaglandins, and blood flow to the kidney tissue drops. The nephrons receive less oxygen, less nutrition, and they begin to suffer. One pill for a headache in an otherwise healthy person, not a major concern. But daily or near daily use over weeks and months, especially after 50 when your kidney reserve is already lower than it used to be, that is a different situation entirely. That pattern can cause a slow, progressive loss of filtration capacity. In medicine, the condition is called analgesic nephropathy, kidney damage caused specifically by chronic painkiller use. And here is what makes it so dangerous. It does not announce itself. There is no stomach ache, no change in urine color, no pain in your back over the kidneys. Just a gradual silent decline that shows up only on blood tests most people never think to request. The second medication will shock many of you because it is considered completely harmless. Proton pump inhibitors. Omeprazole, pantoprazole, Nexium, Prilosec, the acid reflux pill. Doctors prescribe it casually, refill it automatically, and rarely revisit whether you still need it. PPIs work by shutting down the proton pumps in your stomach lining, the tiny mechanisms that produce stomach acid. They were originally designed for short-term use, 2 to 8 weeks, for active ulcers and severe reflux. In practice, millions of people take them for years, sometimes decades, because nobody ever said stop. Here is the kidney connection most patients never hear about. Chronic PPI use is associated with acute interstitial nephritis, an inflammatory reaction inside the kidney tissue itself. This is not caused by the acid reduction. It is an immune-mediated response where your body begins reacting to the drug or its metabolites as if they were foreign invaders. The kidney tissue swells. Nephrons get compressed and damaged. Filtration drops. And on top of that, long-term PPI use is linked to a measurably higher risk of chronic kidney disease. This is not a one-pill event. This is the result of years of continuous, unquestioned use. How long have you been on your acid reflux medication? Has anyone, At any point suggested revisiting whether you still need it. The third medication on this list is the one people switch to when they hear NSAIDs are dangerous. Acetaminophen, Tylenol, the safe painkiller. And in moderate short-term use, it generally is gentler on the stomach and the kidneys, but there is a threshold, and most people have no idea where it sits. The maximum recommended dose is 3,000 to 4,000 milligrams per day. That sounds like a lot, until you realize that acetaminophen is hidden inside dozens of combination products you may already be taking. Cold medicines, nighttime sleep aids, prescription painkillers. You take your Tylenol for your knee, then you take your NyQuil for your cold, and you have just doubled your acetaminophen load without knowing it. Here is the kidney pathway. Chronic overuse generates toxic metabolites that accumulate in the renal medulla, the inner tissue of the kidney, and cause a condition called papillary necrosis. That is the death of tissue at the very tips of the kidney's internal structures. This is the same analgesic nephropathy pathway we discussed with NSAIDs, just through a different biochemical door, and the danger multiplies dramatically when people combine the two. Alternating Tylenol and Advil throughout the day for chronic pain, which millions of people do, hits the kidney from two directions simultaneously. Let me be clear, this is not about fear. Acetaminophen is a useful medication, but after 50, dosage, duration, and hidden sources matter enormously for the organs doing the filtering. The fourth medication is one most people take for a short course and never think about again: antibiotics. Not all antibiotics damage kidneys, but certain classes carry well-documented risk, and if you are over 60, you need to know which ones. Fluoroquinolones, drugs like ciprofloxacin and levofloxacin, can form crystal deposits inside the kidney tubules and in some cases trigger acute interstitial nephritis, the same inflammatory kidney reaction we discussed with PPIs. Aminoglycosides, drugs like gentamicin, typically given intravenously in hospital settings, are directly toxic to the cells lining the kidney tubules. They do not just stress those cells, they kill them. The risk increases sharply in patients who are dehydrated, who are already over 60, or who are taking other kidney-stressing medications at the same time. The key message here is simple. If you are prescribed an antibiotic, especially for longer than a standard short course, ask one question: is this one that requires kidney monitoring? That single question can change the entire conversation with your doctor. You have now heard about 4 medications that millions of people take regularly without ever being told about the kidney risk. And I know exactly what happens next for most viewers. You watch, you feel a knot forming in your stomach, and then you go back to your evening. Nothing changes, but right now you have an option most people do not know exists. CareHealth is a free platform that connects you with healthcare options, screenings, and clinical trials in your area, including kidney function screening, chronic disease monitoring, and new treatment research. You fill in a short form, date of birth, gender, a few basic details, takes 30 seconds, and CareHealth matches you with relevant options near you. No cost, no commitment. Click the link in the description or scan the QR code on screen with your phone camera. As your doctor, this is what I would tell you to do. Do not just watch this video and wonder. Find out where your kidneys stand right now. Now, back to what you need to know about the remaining 5 medications. The 5th medication is one that over 90 million Americans take every single day: metformin, the most widely prescribed diabetes drug in the world. And for good reason. It is effective, it is inexpensive, and it is generally well tolerated. I am not here to tell you metformin is dangerous, but there is a critical condition attached to this drug that far too many patients are never told about. Metformin requires adequate kidney function to be safely cleared from the body. When your kidney filtration drops below a certain level, measured by a lab value called eGFR, estimated glomerular filtration rate, metformin stops being cleared efficiently. It accumulates in the blood, and when it accumulates, it can trigger a condition called lactic acidosis, a buildup of lactic acid in your bloodstream that can become life-threatening. Here's the problem I see over and over again in clinical practice. A patient starts metformin at 52. Kidneys are healthy, the drug works beautifully. Nobody rechecks kidney function for years. Meanwhile, that patient ages, filtration naturally declines with every passing year, and what was once a perfectly safe dose quietly becomes a risky one. The drug did not change. The kidneys did, and nobody updated the prescription to match. This is not a reason to fear metformin. It is a reason to insist on regular kidney function blood tests, specifically creatinine and EGFR, at least once or twice a year. If you are on metformin right now, ask yourself honestly, when was the last time your doctor checked your kidney numbers? Do you even know what your EGFR is? If the answer is no, that is the conversation you need to have at your next appointment. The sixth medication is going to confuse people, and that is exactly the point. ACE inhibitors like lisinopril and enalapril, ARBs like losartan and valsartan. These drugs are prescribed specifically to protect the kidneys in patients with high blood pressure and diabetes. They reduce pressure inside the glomeruli and slow the progression of kidney disease. So how can a kidney protective drug damage the kidney? Here is the paradox. These medications work by dilating the blood vessel that exits the glomerulus. That reduces the filtration pressure inside the nephron and protects it over the long term. Under normal conditions, that is exactly what you want. But if kidney blood flow is already compromised due to dehydration, severe heart failure, or a narrowed renal artery, that same pressure drop can reduce filtration too far. Creatinine rises acutely, kidney function declines suddenly. The medication did not change. The circumstances around it did. Dehydration during a summer heat wave, a stomach virus with vomiting and diarrhea for 3 days, a new diuretic added to your prescription without anyone reconsidering the ACE inhibitor dose. These are the real-world scenarios that turn a protective drug into a harmful one. And here is the combination that every person over 60 should know by name. Doctors call it the triple whammy: an ACE inhibitor plus a diuretic plus an NSAID taken at the same time. That combination dramatically raises the risk of acute kidney injury, and it is disturbingly common. The blood pressure pill your cardiologist prescribed, the water pill your internist added, and the ibuprofen you bought yourself for your knee. 3 medications from 3 different sources, none of them coordinated, all of them landing on the same 2 organs. The 7th medication is one that millions of older adults take every single morning with their breakfast. Diuretics, water pills, furosemide, hydrochlorothiazide. They are among the most commonly prescribed drugs for people over 50, used for high blood pressure, heart failure, and fluid retention, and they are often necessary. I want to be clear about that. Here is how they work. Diuretics force your kidneys to excrete more water and sodium than they normally would. That lowers your blood volume, reduces your blood pressure, and relieves swelling. The result feels good. Your ankles are thinner, your breathing is easier, your blood pressure numbers improve, but your kidneys pay a tax for that forced labor. Every time the fluid volume in your bloodstream drops too low, blood flow to the kidneys themselves decreases. The nephrons, those irreplaceable filtration units we discussed at the beginning, get starved of oxygen and nutrients. They cannot filter what they cannot receive. Chronic, aggressive diuretic use without adequate fluid monitoring can cause a condition called prerenal azotemia. That is a clinical term for kidney dysfunction caused specifically by insufficient blood reaching the kidney. The kidney itself may be structurally intact, but it is being choked of supply. On top of that, certain diuretics alter the balance of critical electrolytes, potassium, sodium, magnesium, and those imbalances can impair kidney tubule function over time in ways that accumulate silently. The message here is not to stop your water pill. The message is that diuretics require monitoring, regular blood tests for kidney function and electrolytes. If you are on a diuretic right now and nobody has checked your labs in 6 months or more, that is a conversation you need to have with your doctor immediately, not next year. Now, the 8th medication catches people completely off guard because most do not even think of it as a real drug. Sodium phosphate laxatives. Fleet enema. Over-the-counter bowel preparation products. You can buy them at any pharmacy without a prescription. Most people consider them routine, harmless, something you use before a colonoscopy or when constipation has been dragging on for days. In a young, well-hydrated person with healthy kidneys, they usually are fine. But in patients with reduced kidney function, dehydration, or advanced age, sodium phosphate can cause a rare but devastating condition called acute phosphate nephropathy. Here is the mechanism. The excess phosphate from the product floods your bloodstream. Your kidneys attempt to filter it out, but the concentration is too high. The phosphate combines with calcium and crystallizes directly inside the kidney tubules, physically blocking them with calcium phosphate deposits. Think of it as cement hardening inside the plumbing. The damage can be permanent. The FDA issued a safety warning about this years ago, but the products remain widely available on pharmacy shelves, and many older adults reach for them without knowing the risk. Let me be precise about this. This does not mean every laxative is dangerous. It means this specific type, sodium phosphate-based products, requires caution, particularly if you are over 55 or if you do not know your current kidney function numbers. Safer alternatives exist. Polyethylene glycol-based options, for example, do not carry the same risk. If you use laxatives with any regularity, this is worth discussing with your doctor at your next visit. The ninth and final medication on this list is the one nobody expects, and I saved it for last deliberately because I know that many of you have been nodding along to every pharmaceutical warning in this video thinking, that is exactly why I take natural supplements instead. I need to tell you something uncomfortable. The supplement industry in the United States is not regulated the way prescription drugs are. Prescription medications must prove safety and efficacy through rigorous clinical trials before they reach a patient. Supplements do not. They go directly from manufacturer to store shelf, with no requirement to demonstrate that they are safe for long-term use. And certain popular supplements are documented kidney toxins. Ursodeoxycholic acid, found in some traditional herbal remedies, causes irreversible kidney fibrosis, scarring that destroys nephrons permanently. High-dose vitamin C supplements, the kind people megadose during cold season, can form oxalate crystals inside the kidneys, the same crystals that make up the most common type of kidney stone. Creatine, used heavily in fitness culture and increasingly marketed to older adults, puts measurable additional filtration load on kidneys that may already be working at reduced capacity. Even turmeric and green tea extract, supplements that people take specifically because they believe they are protecting their health, have documented case reports of kidney injury when taken in concentrated form at high doses over extended periods. The message is not that every supplement is dangerous. The message is that the word natural does not mean safe for your kidneys. Everything you swallow, every single day, passes through the same 2 fist-sized filters. If you take supplements daily, your doctor needs to know about every one of them, and your kidney function needs to be checked. Now, a clear, practical summary. You have just heard 9 medications that can damage your kidneys. Let me list them one more time so you can write them down or screenshot this. NSAIDs like ibuprofen and naproxen, proton pump inhibitors like omeprazole and Nexium, acetaminophen at high or hidden doses, certain antibiotics, specifically fluoroquinolones and aminoglycosides, metformin when kidney function has declined unchecked, ACE inhibitors and ARBs in the wrong circumstances, diuretics without proper lab monitoring, sodium phosphate laxatives in older or dehydrated patients, and concentrated herbal supplements that bypass regulation entirely. Here is exactly what to do with this information. 1. Make a complete list of every medication and supplement you take daily, including over-the-counter drugs and herbal products. Bring that list to your next appointment. 2. Ask your doctor specifically for a kidney function panel, creatinine, eGFR, and a urine albumin test. Know your numbers. If you do not know your eGFR right now, you do not know your kidney status. 3. Never stop a prescribed medication on your own because of this or any video. The risk of stopping may be far greater than the risk of continuing. What you do is bring informed questions to the person prescribing it. 4. If you are taking any of the combinations we discussed, the triple whammy, a PPI for longer than 8 weeks, metformin without recent kidney labs, flag those specifically. Your kidneys do not announce their decline. By the time symptoms appear, the damage is extensive and often permanent. The only defense is awareness and regular monitoring. And remember, that free kidney screening link from Care Health is in the description. 30 seconds could make a real difference.